as you can tell from my titles, I work actually in the Child Health Advocacy Institute in addition to running the Mid-Atlantic Center. The Mid-Atlantic Center kind of fits within the Child Health Advocacy Institute at Children's National Medical Center. You've all heard, I'm sure, about some advocacy activities either in undergraduate school, medical school, public health school, something or another. But I want to see if we can kind of engage in a conversation about how this fits, in your professional lives going forward. So just tell me your name and where you're from and where you are in your life's work.
I'm Dana Faribault from Drexel College of Medicine in Philadelphia. I'm a generalist, but I'm also the,
Generalist like family physician?
No, general OBGYN.
Okay.
Sorry. And I guess my technical title would be Director of Undergraduate Medical Education for OB-GYN. So I work with med students in years 2, 3, and 4, and I'm now Associate Program Director as well.
I'm Caitlin Nettleson. I'm a second year OB resident at Penn.
I'm Fran Branch. I am a second year doctoral student at the School of Public Health at George Washington.
And in my children's environmental health class this fall.
I'm Bob Gould. I worked for over 30 years as a pathologist at Kaiser Hospital in San Jose, and now at UCSF, so I'm the Director of Health Professional Outreach and Education for the Program on Reproductive Health and the Environment. I also, a lot of my own environmental health work has been with Physicians for Social Responsibility. I've been president of the San Francisco chapter since 1989, and also on the national board. I'll be incoming president again for next year.
I'm Alexis. I'm from Newport News, Virginia, where I'm doing the residency. I'm first year resident in the OB-GYN program there.
Okay. So, as you might assume, given that I work for Child Health Advocacy Institute, I certainly believe that advocacy can fit in the professional role for physicians, but the question is, really, how do you figure this out and how do you do this? So, take a look at this. This was written by Abraham Jacobi in the late 19th century, so you kind of have to get past the 19th century verbiage and the fact that there's only male pronouns, and in spite of the fact that he was actually married to one of the few female physicians of his day. But anyway, tell me what you think about what he said. Thoughts?
I mean, I think it speaks to advocacy that, your education as a physician and science allows you to, identify a problem, potentially find the source, and try to get at the very root of that source, not just treat the disease or not just treat the person, but get to the beginning of it all.
Mm-hmm. So do you feel that, for the physician in the 21st century, does this speak to you in some way, shape, or form, or is this all 19th century hot air, or?
I think that the first and then the last line are pretty pointed in the fact that our status and the amount of energies that we put into our scientific research and caring for patients also places us in a very maybe to our patients, an elevated position of power and knowledge. And so oftentimes, even if you're not looking for it, you end up being a leader, and you have to say one way or the other, or you have to support a group or not support a group. So you have to make big decisions, and then with that power, you're enabled to strike at the roots of evil that you see and maybe know better than others.
So, sometimes we talk about words being engraved in stone, And these words literally are engraved in the walls of the Hubert Humphrey building, which is the building downtown here in DC that houses the Department of Health and Human Services. Hubert Humphrey had been a senator and had been a vice president, and he was dying of cancer, bladder cancer. And he was invited back to address a joint session of both houses of Congress, the Senate and the House of Representatives. And this was part of the remarks that he made. So do you think that a lot of people today feel that this is what governments, should be doing or not? Do you get a sense among your friends or your colleagues or?
You're asking if we think this is what's being done?
Yeah, I mean, do you see this being reflected in government or how people think government should run, whether it's a local, state, county, federal level in the United States today?
I think that that's sort of what we expect from the government, but the government is not necessarily able to do this to the extent that we like due to a lot of politics. So I think that it is expected, but it's not necessarily being performed.
Others have other thoughts or opinions?
$40 billion in food stamp cuts just about to come down the pipe from the Republicans. I mean, without naming parties, but that's just reality.
Then there's also like the Obamacare. I mean, that's supposed to be expanding the coverage and kind of shows like the trend that we would like to help more people.
The question is, who is the we
Yeah.
within the we?
Okay.
I was gonna say, I think yes, it's kind of that idea of yes. I think in general people would like to think that they would like to help everybody, but then when it comes down to it, it's if it doesn't, impinge on me, then I'd love to help you. I'd love to help you as long as I'm okay first.
And then Nelson Mandela, when he received the Nobel Peace Prize in 2001, among other parts of his comments were that more countries have understood that women's equality is a prerequisite for development. And very clearly, even in our own country, we started with women not being able to own property, not being able to vote, and things like that. And there are still many who would argue very clearly in our own country that there is not equality between men and women. And then in a global scale, there certainly are many problems in other countries as well. Kurt Stange is a family physician, and he wrote a paper now about 3-4 years ago, that I found really quite inspiring. To a certain extent, he takes Jacobi's words and brings them into the 21st century in terms of language. But again, he talks, and he's just a fascinating person. We had an opportunity to invite him to Children's National Medical Center. So he's a family physician. He's the editor of one of the various family physician journals, but he's also got an appointment at Case Western Reserve not only in the family medicine department, but in oncology, which is probably not what you would necessarily expect. All this stuff's on the jump drive you got. You're welcome to take notes, but all this stuff is on the jump drive that you got, so you don't have to worry about that. So he's just somebody who thinks in a very broad kind of a way, and I think we all have to remember whether we're certainly if we're in clinical medicine, there are a number of things that we do that we are given permission to do by society, that if they were done by people who weren't healthcare providers, they could be arrested for it. You all do pelvic exams on a daily basis. Some random person in the community who starts doing pelvic exams, they can get arrested. Much less even just the questions that we ask. All of us, whether we received any government loans or grants, all of us benefited in terms of our education from support that went to the schools and go to the residency training programs that we participated in from the federal and sometimes even the state governments. So we get privilege from society. Society supports us tremendously in terms of what we ultimately choose to do professionally. And Stange and I think Jacobi in 19th century language argues that with those privileges and with the support we've had, that there's more to our responsibility back to the community than just what would go on between a single physician and an individual patient or their family. So tell me more about your perceptions as to whether you see healthcare, whether you see advocacy as an appropriate role for you as health professionals. You're nodding yes.
I think it can be. Well, like we said, it is a position of sort of great privilege where people really do look to you to know a little bit more than the general population, and they look to you to make recommendations. And we've seen it with a couple of the celebrity physicians like we were talking about earlier. Like, people really do listen to what physicians have to say, and if you aren't informed or if you don't have a well-reasoned kind of stance on things and you're just kind of talking off the cuff or giving recommendations that are less informed, and you really could be doing your patients a disservice, I think.
Well, I think you're quite right. And, we as a profession have certainly for the last 3 decades or so talked more and more and more about evidence-based care. And we would like to think that everything we do is well based on well-collected evidence. We all know as clinicians that that's not as true as we would like. And as Patrice Sutton's going to talk about in a few minutes when we go back to the main room, when you're thinking about environmental health, among other things, for example, to do randomized controlled trials related to environmental health issues would generally be unethical. So, how do you function in an evidence-based world when at least what some people have thought is the sine qua non of developing evidence shouldn't actually be done. And so I mentioned the article that Stange wrote, and then in Academic Medicine Huddle at about the same time, so it was almost like an unintentional debate, was talking about advocacy on behalf of societal goals is inevitably political. Civic virtues are outside the professional realm, and the profession of medicine ought not to require any particular political stance of its members. So how do you feel when you hear what Huddle's had to say? Where does he have good points? Where do you agree? Where do you disagree?
I think the first point is very true. It's sort of what I was saying earlier, that if you really want to have real change in the U.S., it has to go to the political level at some point. And I mean, as a physician, it really is important for you guys, I think, to remain, impartial. I would want my physician to be rather impartial, but to be well informed at the same time.
But what about for you, Fran, as a public health professional? I mean, you're working on your DRPH. You're going to be, in a respected position at a university or a health department or something. So you have the potential to participate in a lot of these debates. I mean, it's not just physicians.
I think that's more my job. I think that's more my responsibility to be an advocate rather than other professions. But I think that's public health in general, is to advocate for the health of people and to do what we can in order to change it.
Other thoughts?
Yeah, jump in, but this debate, I could certainly just reflect on in terms of my own experience with Physicians for Social Responsibility. Our organization was founded in the early 1960s because a number of the founders of PSR were confronting the public health threat raised by nuclear weapons testing in terms of what the broad, the global impacts of that testing were, as well as the dangers of nuclear war. And the founders of PSR submitted a number of articles to the New England Journal of Medicine, a special edition in 1961, or 1962, I believe. And that documented in the scientific way that we're responsible to be scientists on the one hand, what the actual impacts of nuclear war would be, documented the deaths that would likely happen, documented that we didn't have enough doctors and other health professionals who could likely survive a thermonuclear war. We wouldn't have enough burn beds from the destruction, things like that. So that's a scientific piece in terms of the argument. But then took the position, which is more the public health position, in terms of looking at upstream issues, that physicians needed to then act, and it's in line with the other points of view that are here. If you recognize that type of problem, that physicians had an obligation to prevent that from happening, basically to prevent what you cannot cure in your general role as a physician. And that was, really the core of our organization, starting off in sort of what we've carried off in terms of climate change and other types of work that we do. And I think a lot of this, in terms of public health versus medical practice, in many ways goes back to the divide between the two disciplines at the beginning of the last century, when you had schools of public health, then you had schools of medicine, and they went off in their own way. And personally, I find that most of the advocacy that I do as a physician, or even short of that, just giving scientific presentations about certain subjects that would be considered political, like climate change, which was the way people related to me 15 years ago when I would try to bring this up. That's just politics. What does this have to do with health? Reflect the need to talk to our colleagues and sort of reinfuse concepts of public health.
And so certainly one of my goals in this session is to try and convince you that advocacy is not inevitably political in terms of partisan politics, Republican, Democrat, things like that. It may imply engagement with political systems, but it doesn't at all necessarily have, and in fact should not imply that you are necessarily engaging on behalf of one political party or another. Now, I also recognize that there are very clearly degrees of involvement in public policy and advocacy that different physicians, public health people are going to be comfortable with. And I certainly wouldn't say that every public health person or physician would have to be part of an institute on health advocacy the way I am, and spend a reasonable part of every week dealing with public policy issues. So I'm not saying that people have that this has to be a subspecialty interest of every physician by any stretch of the imagination. These are some other comments that Huddle made in his paper in Academic Medicine, and again, I really disagree very strongly, although I think in particular there are a number of people who are involved perhaps more in the bench research side of things in academic medical centers who find the notion of being involved in any public arena very discomforting for them. The one thing that I really point out to them, and I think is extremely important for them to recognize, their very existence depends on public funding. You know, the vast majority of research funds in the United States filter through the NIH. And if the NIH went away tomorrow, most universities, certainly most medical schools, and actually large parts of many universities would close. There is no way that they can function without the federal dollars. And so if they don't want to, you know, if they, you know, they need to think about looking at which side their bread is buttered on before they decide that being involved in public policy discussions is beneath them. So how do you define advocacy? I mean, what, you know, we talk about it, but what does it actually mean?
Standing for the rights of your patients.
Yeah, and I think most clinicians, you know, in their own office, one-on-one, you know, we all have, you know, called the insurance company. We have all tried to get people enrolled in programs that we think would benefit them that they didn't know about or didn't choose to get enrolled in. The first bullet point here is an actual dictionary definition, and then some of the others are from medical and public health publications. I really prefer the one that I've bolded there, interestingly enough, from the journal Ambulatory General Pediatrics, but it's a Japanese journal, but it's an English language publication. The application of learned skills, information, resources, and action to speak out in favor of causes, ideas, or policies to preserve and improve the quality of life, often for those who cannot effectively speak out for themselves. And ACOG actually has a definition that was on their website. This particular citation of that definition was from an article in Current Opinions in Obstetrics and Gynecology in 2012. So ACOG defines advocacy as a coordinated combination, problem identification, solution development, derivation of strategies and actions to create positive change. And then they go on to talk about federal, state legislative action. But again, I look at it through the other end of the pipe, if you will, the other end of the telescope, whatever analogy you want to use. That I would argue every healthcare professional needs to be an advocate with their individual patients and/or the families that they're involved with. And then, as we'll talk about in some other work that people have published, there are other realms of advocacy that people can choose to become involved in. But so, what are some of the things that advocates do? What can you do to be an advocate?
I think what you said, it depends on what level.
Mm-hmm. So calling the insurance company is one
it's-
thing. Fran, you were going to say something?
I was going to say education could be a great form of advocacy.
Yeah. I hope what we're doing here today, by exposing, you know, I think obviously environmental health is extremely important, and not only to pediatricians but to physicians as a whole. And one of the other things I'm working on right now is within the confines of George Washington University School of Medicine. They're talking about doing a curriculum renovation, and I'm advocating with the person who's directing that curriculum renovation to include concepts related to environmental health in the curriculum. So I think education very much goes a long way, and that is really you know, a large part of particularly those of us what we do in academic medicine. But again, even people who are in clinical practice, we're educators of our patients and their families every single day. And one of the things that's become obvious to me, having spent 30 years in primary care and spent a lot of time either in state houses or up on Capitol Hill here in DC, that the skills that I have and that everyone in this room has in terms of sitting down with a patient or a family and taking what we know and translating it into a format that is, on the one hand, comprehensible by the people that we're talking to and actionable by the people that we're talking to, are really the same skills that are required in sitting down and talking with a legislator, somebody who works in an executive branch agency, staff people who work for legislators or executive branch groups. So we don't give ourselves credit for skills that we really already have, and I think for many people the notion of going to talk to a staff person in a congressional office is a very anxiety-provoking notion, but the reality is it's not a whole lot different than what you do every day. And I want to, so these are a whole bunch of things. I mean, I don't know if any of you, maybe when you were students, may have even gone picketing or whatnot. You don't have to do any of these things. And one of the things I want to show you how to do is, as an extremely busy health professional, what's one of the easiest, simplest, and most direct activities that you can undertake when you don't have any time, because none of us have any time. So, both the United States Senate and the United States House of Representatives have websites. Senate.gov, House.gov. Okay? When you go to the Senate website, it says find your senator, and when you go to the House website, it'll say find your member of Congress. The senators are arrayed by state, and on the House website you put in your zip code, and the machine does all the thinking for you. I live, well, actually here in Virginia, since we're across the bridge from DC. I live here in Virginia. This is a screenshot I took a year or so ago, so Jim Webb is no longer my senator, but you get the basic idea. So I put in Virginia, and it came up with Mark Warner and Jim Webb. And one of the things I want to point out to you is this web form, because this is the key. Many state legislators now have exactly the same things on their websites. So when you click through and go to their form, it's very easy to populate. And then down here, you can type, 3 words, 1 sentence, a paragraph, vote for this, don't vote for that, or you can, I've forgotten, they've usually got a couple thousand word limit, so if you really want to, spend time, you can write an essay. One of the reasons that you should use this is not only because it's quick and easy, and we're all nowadays pretty comfortable with using the internet and drop-down menus and all that sort of thing, but what I've circled here in red, since 2001 and the anthrax-laced letters that were sent to Capitol Hill, no mail goes directly to the White House or the Capitol any longer. All mail goes to a facility out in Landover, Maryland, where it's cobalt-60 irradiated. The same way that a lot of the prepackaged stuff that we peel apart and use gets irradiated before it comes to us. Not the stuff that the hospital does, but the stuff that comes from companies. And so snail mail. When you talk snail mail, you're really talking snail mail here, because by the time it has to go out to Landover, get radiated, and then sent back to the White House or the Hill. The other thing is, I live here in Virginia and in Northern Virginia, so I'm real close here to DC. But for those of you who don't live near DC, you may think that, well, visiting my congressman or visiting my senator is difficult. Every senator has multiple offices throughout the state that they represent, and every congressman or congresswoman has multiple offices within the district that they represent. So you can make a visit with a staff person close to where you live or work, just because I live here in DC, I can go up on the Hill, and it's this, when you're talking to the staff people, it's more or less the same, not exactly, but more or less the same, whether you're talking to people in the local or regional office or you're talking to people here in DC. So these are things that you can do, are easy to do, quick to do. ACOG has a Legislative Action Center, and if you sign up with the ACOG Legislative Action Center, they will, I don't know with what frequency, I know when I've done this with the American Academy of Pediatrics, I mean, it's about 8 times a year. It's not, you're not gonna get inundated. And they'll send you a letter to read, and then if you put in your zip code and click through, then with probably about 5 mouse clicks, you will automatically be able to send a letter by the same mechanism to your member of Congress. So again, for your finished call, you've got 5 minutes before you're ready to fall into bed. You look at your email, you've got something from ACOG, you can click through and you can be done. Now, and that may be all that you want to do, that may be all that you're comfortable doing, but I also know from surveys that have been done asking questions to people who work on Capitol Hill as the staff member in these offices as to do these things make a difference? They do. They really do. They maybe don't have the impact of some victim coming from the district to talk to the member of Congress, a breast cancer survivor, a uterine cancer survivor, an ovarian cancer survivor, coming to actually meet with the elected representative. That's going to be more impactful than these kind of things. But these do matter. And since we all can't bring people to the Hill, and we all don't necessarily have time to come to Washington ourselves, this is the kind of stuff that we all can do. In terms, again, I said a few minutes ago, evidence-based honesty. You're translating medical information to policymakers, and I think when we move into the advocate mode, if you're advocating with your spouse or significant other, or when you used to advocate or still advocate with your parents or whatever, sometimes maybe you'll exaggerate a little bit. You really want to go to this place for dinner or that place for the weekend, and you'll talk about all the benefits, and maybe you go a little overboard. But you really have to be extremely careful to resist that impulse that I think we all have, because we know what we want to have the outcome be. But the reality is, if somebody catches you in an exaggeration, then your credibility is all gone, and your effectiveness into the future is all gone. So it's just really important to be evidence-based.
If I just might reinforce that, because it's as important if you're going on the Hill, but also among our colleagues. And whether you're giving a grand rounds, you don't want to exaggerate, you don't want to preach, you want to be scrupulous about your scientific information. And even if you believe one thing or another, to always not only be clear to yourself, but to really separate that out in terms of making a presentation. I've worked for, I guess, 19 years now as a delegate to the California Medical Association, which is a very conservative group. Excuse me?
The CMA?
Yeah.
I went to Loma Linda, and we were involved with the CMA a lot.
Oh, okay. Okay, yeah. And, when I started, I wondered whether things that I believed in, I thought were important, how they connect with people who were largely, in my delegation and others, more conservative than myself, in the main. There are individuals there. But over the years, we've worked very collegially on supporting policies on pesticide reduction, protecting farm workers from pesticides. It was so important for me to present the issues very clearly and without hyping them, to connect with people. And I just found from my own experience that if you had that style of work, if you will, with people, they respected it and they would support you, particularly if you were appealing to them, to their heart, what made them go into medicine in terms of serving people and the same type of advocacy, extending the sort of sense of advocacy for your patient's health to the community health. And because of that, it had a great deal of power in terms of getting policies that got passed at the California level, that moved up to the American Medical Association, including climate change and other reductions of toxic. So I would just really underscore the importance of, a good style of work that way. That's ultimately is based on those criteria that Jerry sketched out.
And let me give you an example in terms of the patient's persistence and coalition building. So, when we're fellows in our training, we all do some project, a research project, whatever kind of research project, but we all do one. And so when I was at that point in time, it was called a fellowship in ambulatory pediatrics. So this was the mid-1970s. Car seats had just come out on the market. Most pediatricians didn't know about them. Parents didn't know about them, and most parents didn't use them. And it was also a time in medical history, if you want to call it that, when women who had normal deliveries stayed on the postpartum floor for 3 days. And so that did mean, among other things, that you could do much more detailed postpartum teaching than might be possible today. And so I devised a project to teach moms about the use of car seats, and we got some actual car seats donated to us. And then the building where our primary practice was located on the hospital campus had a parking lot that was separate from the main hospital parking lot. And the waiting room of our office overlooked the parking lot. So I could have a research assistant who knew the schedule of the parents who were bringing their babies back for their checkups, look into the parking lot and see whether the parents actually brought the child in the car seat or not. So it wasn't just a self-report. I had taught them about the use of the car seat. Did you use it? Yes. But we could actually observe them. And so then when I moved to my first faculty position, the American Academy of Pediatrics chapter in Ohio was interested in getting a seat restraint law passed, and the president met me and knew what I had done before coming and asked me to take the lead on that. And so it took us 3 legislative sessions to get the law passed. The member of the legislature who was interested in helping us had actually been a school teacher before he went back to law school, and then got elected as a member of the House of Representatives, so he was interested in kids' issues. That's how we got him on board. But this process took long enough that he ultimately ended up in the Senate. I can't tell you the number of parents groups and other groups that I had to work with in order to get this law passed. And if anybody is interested, I don't know why you would be, but if anybody is interested, there are over 500 individual police departments in the state of Ohio. And if you're going to pass a law requiring parents to put their kids in car seats and you expect the police to enforce that law, you've got to start building coalitions, not thankfully with all 500, however many it was. I could not believe, I still can't believe, as you can tell from my tone of voice. But so coalition building, figuring out who are going to be your partners in this process, because it's extremely rare that we as a health professional are going to be able to pull off whatever advocacy idea we have alone, all by ourselves. We don't have the political clout. So this may be the easier part of the thought process, but what barriers do you perceive in your professional, personal lives to becoming more engaged in advocacy?
Time.
Yeah, that's the big one. And I hope I've given you at least some idea of how to do something in a limited amount of time. What else?
I guess going along with that, becoming part of a coalition, how do you find partners to work with you?
Well, I think that's a very good point. I think what Bob alluded to, certainly my own personal experience, find a professional society. I would guess, I certainly know this is true within the world of pediatrics, there is no, you've got the American Academy of Pediatrics as the overarching pediatric society. You've got 3 societies that relate primarily to pediatricians and academic medicine: the Society for Pediatric Research, the American Pediatric Society, and the Academic Pediatric Society. You've got then a whole host of, the peds oncologists, the peds pulmonologists, the peds endocrinologists, the peds nephrologists, whatever ology there is out there, they've got their society too. But I would bet you a very nice meal somewhere that every one of those societies now, not 20 years ago, but now, has a committee on public policy and advocacy, or at least some people on the board. And some of those societies actually subcontract. The American Academy of Pediatrics has a government affairs office here in DC. And some of those societies, specialty societies, actually subcontract with the AAP for the lobbyists to do the public policy work for, because they're not based here in DC and they need people on the ground on a daily basis. So I know, in terms of what I've already pointed out to you about ACOG, and from what Dr. Connery has told me in other meetings that I've had with her and what she was talking about today in terms of the ACOG legislative meeting, federal legislative meeting yesterday, and the meetings that go on today and tomorrow around state legislative activities, ACOG could very well be a home. And that starts you out with professional colleagues and then can help you build out among other colleagues. The other colleagues sometimes then also come when you work on this stuff at the local level. Because then, like again, when I was doing some of the car seat stuff, parents were coming to me and asking me for their help, and I made them, partners in the process. So when you deal at the local level, it's sometimes a little easier. You've got easier entree, and then you can build at the regional or the national level. So again, time, resources. One of the things, again, I want to point out to you, you all think, if I had to guess, that understanding how the government works is hard, and it's not something that you can do. But tell me if at one point in your career, I'm not saying today, but at least one point in your career, you could talk intelligently about the Krebs cycle, right? Okay? So if you could learn about the Krebs cycle, you can learn about how government works. Okay? You're smart people. It doesn't mean it's easy. Learning about the Krebs cycle wasn't easy, and I was a biochemistry major, but be that as it may. So, you can get that knowledge. And if you really want to get involved in this, ACOG, other professional societies, sometimes even your own local hospital will even do specific training for you. I know a number of years ago, PSR took me on a very nice retreat one long weekend and taught me all sorts of stuff about media interviews. The American Academy of Pediatrics has taken me on activities to learn about how to talk to people on the Hill, do media interviews, and even my own hospital, Children's National Medical Center, gave me some media training just because they wanted a subset of their physicians to be able to deal with the media. So there are ways to work around a lot of these barriers. So this is from a paper that appeared in JAMA back, when the heck was this? 2004. Yeah. Why these are non-concentric ovals as opposed to concentric circles, that part I've never figured out, I would think. But at any rate, so Gruen et al. Talk about what we've sort of talked about here a little bit. And they put this in domains of professional obligation versus domains of professional aspiration. And they would argue that all physicians must be advocates at the individual patient care level to ensure that there is access to care, and in some of the direct socioeconomic influences over the provision of care, like can people pay for their prescriptions, can they get a walker if they need a walker, or crutches if they need crutches, or other devices or things like that. Whereas some of the work that maybe I or that Bob have been involved in related to some of the broader socioeconomic influences and the global health influences, they would argue are not things that people must do, but that certainly some people can do, and some people find that they really want to do. And in terms of specifically related to environmental health, I don't know if any of you have seen this publication that came out this spring from the Royal College of Obstetricians and Gynecologists on chemical exposures during pregnancy, dealing with potential but unproven risks to child health. So I saw this and then actually was speaking to slated to speak to some pediatricians in London this summer, so I went through it in a lot of detail. And I would tell you, had they turned this into my course, I don't usually give grades for effort and execution. I only give one grade for any particular paper. But had I been grading it in that way, I would have given them an A for an effort, but a C for execution. So why the A for effort was just that they thought to put this down as a policy paper, which they had never done before. The Royal College the Royal College for Pediatrics and Child Health has never done anything like this. I don't know about other societies in Great Britain, but they totally ignored any role for their professional society in tackling this problem. They totally ignored any role of industry in dealing with this problem, and they totally ignored any role for government in dealing with this problem. And so that's why I give them a C for execution. And I will admit these are quotes, that aren't, I'm not giving you the whole context, but at any rate, they talk about the mother as the gatekeeper of her baby's future health, and any external influences on the baby predominantly come from the mother. Well, that's not a dynamic that I, as a physician, would want to set up, certainly with one of my patients. But I know, as when I've read the literature on lead poisoning back in the 1950s, the 1960s, there was a lot of sort of blame the victim. So if you read a lot of that literature, oh, these kids get lead poison because their parents don't supervise them well. That's why they're eating the paint chips. As if a parent could stand over their kid, for all the hours of the day that they're awake. And we also didn't at that time realize that a lot of it came from microscopic dust. And the lead compounds that are in paint are actually sweet. So if the kids do pick up a macroscopic chip of paint and put it in their mouth, there's no yuck factor, it tastes good. And so they're positively reinforced to do it again. And then they go on to say the main focus will be on examples of chemical exposures that are modifiable, and I've added to the emphasis. But the reality is you go to the store, I go to the store, all of us go to the store, and even if we read the labels, how do even we interpret them sometimes? How do we know to choose this set of ingredients versus that set of ingredients? So that was some of the reason why I gave them a C. Then, in terms of some of the legislation here in this country that I would like to see obstetricians and gynecologists get involved in, and I'm very hopeful that in the very near future we'll see some involvement here. There is a law called the Toxic Substances Control Act, which was passed in 1976, which does not control toxic substances, is in horrendous need of rewriting, and people have been working on that for several decades. And the Toxic Substances Control Act is supposed to be concerned with all sorts of chemicals in commerce. And then particularly, in terms of women's health, children's health, things that are used for washing, things that are used for shampooing, things that are rubbed on or applied in some other way to the body, such as personal care products, they actually toxic may or may not have some influences on what gets into personal care products, but rewriting of TSCA isn't going to solve all the problems with personal care products. So there's the Federal Food, Drug, and Cosmetics Act, the Consumer Product Safety Act, and even the pesticide law, the Federal Insecticide, Fungicide, and Rodenticide Act, that come into play. So, for example, you've got a soap which contains triclosan, the antibacterial agent, and I hope none of you use that, but be that as it may, that actually makes it a pesticide and falls under EPA regulation. So, in summary, I would say, you can use some snail mail for your local city council, county council, things like that. I've showed you how to get in touch with your members of Congress. get involved in ACOG or some other group that makes you happy, where you'll find people of a like mind. And these are some of the priorities that ACOG has in their 2013. Now, I don't know whether this was revised yesterday or whether this actually is what will go forward for the coming year. But at any rate, I'm sure you can find it on the website as to whether it got revised or not. They put stuff in their news. They actually have a video you can download to get more insight. And one of the things I really want you to be aware of is this Junior Fellow Rising Star in advocacy. So they sponsor a fellowship where residents can do a 1-month elective in the Government Affairs Office of ACOG here in Washington, D.C. And then there are other groups, the NPA, IMAP can provide you with a lot of background information for the teaching that you might want to do. One of the ways that I got into this was long ago and far away. I came to DC for 1 year as a Robert Wood Johnson Health Policy Fellow. It's been an extremely long year. That was 1985. AAAS has a fellowship. The American Public Health Association has fellowships. Congressional Black Caucus has a fellowship. These are not all necessarily for physicians. The RWJ takes PhDs and social workers and psychologists and nurses, et cetera, et cetera. The Kennedy Foundation particularly focuses on issues of developmental disabilities. And again, this is that OBGYN fellowship that I mentioned. So, yeah, Bob.
Just wanted to underscore the involvement with ACOG. I mean, I think I find it very exciting seeing Dr. Conner's presentation and what it means that there's going to be this committee opinion that's going to provide an environmental health framework towards practice. But I have to say, even before these developments happened at the national level, I have to say, going back to the California Medical Association experience, how important it was that the local ACOG people showed up at California Medical Association for the reference, as well as the local American Academy of Pediatrics chapter. So you weren't alone as this, the likely suspect, the political person, but you really had institutions support, and it made all the difference in terms of the policies that we got through. The only other thing I would say, which goes back to what we were talking a little bit earlier about the movements within hospital systems, Healthier Hospitals Initiative, Healthcare Without Harm, is that there are a lot of different, I mean, even from my experience of 30 years ago, starting in Kaiser and maybe up to about 10 years ago, but at that time with this hospital movement starting, and I can speak to Kaiser's and many other healthcare systems, Dignity Health, et cetera, who've embraced the concept of environmental stewardship as being fundamental to their operations. There's a PR edge to it, but on the other hand, the realities that hospitals are facing in terms of bringing down costs of energy, but also caring about themselves about what are going to be the long-term costs of obesity, diabetes, other things that we've been exploring today. There's much more support for these initiatives within hospital systems themselves. You're not marginalized. In fact, I know that, for example, in Kaiser is one example that I'm most familiar with, the environmental stewardship concept that's been embraced throughout the entire hospital systems includes institutional support for green teams, physician involvement with this sense. And it's cross, it's doctors working with nurses and other people in the hospital system, but having that support allows you to work without, coming up against those barriers, and it's actually facilitated. So the more we could build that movement, it makes it easier for us to be effective advocates and, not at risk to our jobs in that case,
All right.